Welcome, everybody. Welcome back to Perfecting PT for this week. I am joined today by Brian Kokulak. He's based out of New Jersey, and we're going to talk a lot about about ACLs today. So I'm going to give Brian a chance to just kind of introduce himself, and then we'll kind of get going. But for anyone wondering, little brief outline. I know people have said they like that I kind of give them an outline. The goal for today is to talk about the various types of ACL surgery, so you have a better understanding of what actually happened when someone shows up to work with you and they've had one, as well as what those surgeries mean. Are there going to be certain limitations? Are there going to be certain restrictions? Are there going to be certain things that you need to know to make sure that they can heal as best as possible during this process? And then a big one I wanted to talk to Brian about is, how do I know that my ACL people, whether that's an athlete returning to, like, wanting to return to play, or just someone that wants to get back to recreational sports, or someone who maybe doesn't participate in sports at all and got hurt in a freak accident, like, how do we know that they are where they should be? Like, because everyone will say, oh, it's very person dependent. But ultimately, like, if you're at 3 months and can't do this, you may be behind. So I'm really looking forward to learning more about that from you, Brian. And for anyone who is listening, not watching, Brian is a doctor of physical therapy, as well as OCS certified, which is orthopedic certified specialist in physical therapy. So Brian, take it away and introduce yourself if you would.
Yeah, Dr. Brian Kokulak, physical therapist in North Jersey. I'm with Edge Pro Physical Therapy. We're in Paramus, New Jersey. I have a decade of experience working in PT, sport and orthopedic settings, attached to a large training facility. So we see a lot of a gym population, a lot of sport population. Biggest crowds we get are like a lot of high school age football players, lacrosse players, NFL athletes in the area, a lot of MMA, UFC athletes from the area as well. And then on the side, also, I've been an adjunct professor in a PT program. So I love teaching. And just one of the more favorite things I love to treat personally and help people rehabilitate from are ACL injuries.
Excellent. So you had previously brought up, because we chatted on the phone a couple weeks ago to set this up, that there are a number of ACL surgeries. And if I'm being honest, I lump most of them together. And I know I shouldn't. I know that is not a high-end provider like mindset. But can you kind of overlay kind of how many common types of ACL surgeries there are, or ACL like healing processes that there are, and maybe just kind of outline them all, or to go through them in list order, and I'll stop you and ask questions as needed.
Yeah, sounds good. I think starting off the bat, what you typically see when you hear an athlete has an ACL injury is, the patellar tendon repair.
Okay.
That's probably more common. That's the gold standard, especially when you get the skeletally mature athletes, your teenager and above, and a lot of professional athletes, just because it has a lot more tolerance to rotational forces and kind of getting back into sports and the high demand sports, basketball, jumping, football with like the hard cutting. Something else common we're seeing as well are quadricep tendons. We also get a smaller amount of hamstring tendons. Something else that's also can occur is a peroneus longus tendon graft. I've had as well.
Interesting.
And then so those are more of like your reconstructions. Then you can also have a concomitant meniscus pathology going on as well. So if you've had a meniscus repair or meniscectomy, that can have some considerations in a rehab timeline. And then you also can go into your ACL repair surgeries, such as like the Bear implant or an ACL primary repair, which are both growing in a lot more popularity, but both of those actually have a quite a bit different outlook in terms of timeline. And then you can also go into your ACL deficient athlete who has a severe sprain or even a full rupture, but you can become what's called a coper if you meet certain criteria and kind of can progress through a good rehab program, get up to a year mark where you're involved back into your sport, you can be what's considered a coper, where you can operate and play sports without an ACL.
Very cool. So yeah, so for anyone listening, there's reconstructions, there's repairs, and then there's copers. Is that correct, Brian?
Yeah, it's a good way to break it down.
Okay, so like the reconstructions, they are taking a non-ACL tissue and they are using it to essentially replace the ACL. And it sounds like the most common one is the patellar tendon, and that's the one where they go part of the part of the tibial tuberosity, the central part of the tendon, and part of the a chunk of the patella, where essentially they're anchoring bone to bone and kind of yeah, correct. Just making sure. And then the quad tendon, they essentially take it from above the kneecap and they kind of they just kind of thread it through and kind of bolt it in.
Well, no, it's same thing. Just that middle third of the quad tendon is just grafted out and it's just harvested and just same way as the patellar tendon is. And then it's just fixated and reconstructed. Yeah.
Okay. And is it the same with the hamstring and the peroneus longus tendons?
Yep.
Yeah. So they're just looking for a tendon to harvest and then they just slap it in there.
Sure.
I know that's not exactly what they do.
Well, they'll fixate it in there. It's measured to be a correct, precise measurement. It's those tibial tunnels are drilled at certain angles. Like there's a lot more measurements that go into it, but yes, it's fixated to become your new ACL.
Got it. And then the repairs, which I think people are going to be less familiar with. You and I are both familiar with the bear. When we say that, it is not. That doesn't mean they're putting like a bear tendon or anything like that. I often get that question from people. The bear essentially is where they use a bovine, I'm going to say a bovine, what would you call it? Like a bovine collagen, and it looks like a marshmallow.
Yeah, it looks like a marshmallow or like a cotton swab almost is what it looks like. It's fixated. Yep.
And why don't I'm sure you have a better understanding of it. Like I've seen a few of them, but I'd like to hear your explanation. So essentially it's a collagen marshmallow, and what is it that they do with it and why?
They'll basically attach it to one of the stump ends, and it basically forms like a blood clot. And that will stimulate a lot of the healing and the attachment and the vascularization process. And it undergoes just a healing process. There's a little bit more of a protective phase for like those first 4 weeks. Mm-hmm. But patients are weight bearing right away. Just a couple limitations, don't bend past 90. I've had a couple of them where they actually do strictly limit like full arc, no 90 to 0, just while that collagen graft basically heals. Mm-hmm. And one of the positives about it is it does help retain your native ACL. So it retains your own ACL. It's basically just repairing and healing, because mm-hmm. with a lot of the newer research that's coming out, is that we have a lot more vascularization in our ACLs than what was previously determined. So there is more vascularization, there is more of a healing process. And that kind of goes along with some other ligaments that you'll commonly hear injuries on, like your MCL or your elbow, your UCL, where mm-hmm. if it's that proximal half of the ligament, there is just a lot more vascularities within that zone that allow more optimal healing, and it does give it a chance under the right circumstances.
Cool. So I guess that would lead to another one. Would you consider the cross bracing to be part of the repair?
Under the repair.
Okay. And so for people who are not familiar with the cross bracing, they're coming out with a type of ACL treatment, depending. It's quite specific as who can qualify for it. As far as what your tear looks like, how long it's been since your tear, a number of factors, but they're finding that your ACL may be able to spontaneously heal if they brace you in a certain position. Would you tell us more about that, Brian?
That one's actually something I haven't come across as much. That just not as much exposure in, personally with that one.
Well, especially here in the United States, like I think the big country that it's in is in New Zealand. If I'm correct. Yeah. So I'm glad I can contribute a little bit. Yeah. So that one is a little funky, where you have to have like a tear. It has to be at a certain part of the tendon. I mean, a certain part of the ligament, and the tear has to be essentially, I believe it has to be like calm enough that it doesn't just like explode the two ends of the ACL. Like they need to be relatively proximal to each other. They need to be able to approximate to a certain point when the knee is bent, and they brace your knee to 90 degrees for somewhere between 4, 8, and 12 weeks to see if the ACL will spontaneously heal. But it has to be done within 2 weeks of the injury. Otherwise, you don't qualify as a candidate. So it's got a lot going on. I myself have not experienced any. I haven't seen any patients that have tried it. I've seen a couple people online, but they're all from other countries and that are trying it.
Got it.
So I'm curious how long, and how long should an ACL take to, or rather, how long should someone, a healthy average person, be able to take? Like, how long should it take them to get from surgery back to full function, like unrestricted? Because I think I'm a little torn, because if you like, do you follow Wesley Wang at all?
Mm-hmm.
Yeah, so he seems to be a big name in the ACL game, like especially on social media. And it seems that he's very opinionated in thinking that people should take somewhere between 12 and 18 months. But I see other people, they're like, oh, 6 months. Like Aaron Rodgers tore his Achilles and had that fixed, and he's like 6 months, and like, or 3 months. Like, what are your views on, like, if someone has good rehab and a good surgery, what do you believe is an appropriate timeline for someone to expect to return to most activities?
It's going to be between 9 and 12 months. That's a pretty standardized number that we have across the board right now, aside from some extraneous cases. But yeah, clinical research that keeps coming out shows, like, again, delaying return between 6 and 7, 7 and 8, 8 and 9 months. It's like every month you delay is a 50% reduction in re-tear rates. And then once you get past that 9-month mark, it's like, okay, re-tear rates are unfortunately still about 20%. But that's a significant reduction compared to where it was previously, in the leading up months. And that's like, let's say, just strictly ACL, no meniscus, nothing else involved with it. That's your pretty typical timeline. Now, when do athletes, and that's them scoring 90+% on a battery of return to sport tests, strength testing of quads, hip abductors, adductors, hamstring, everything, plus agility tests, speed tests, and then you can get your sport specific tests, if you want to break it down to football or lacrosse athlete or soccer athlete as well. So again, they're hitting the strength standards that are qualify them for return. But again, the more removed you get from a surgery, the numbers and your scores just continue to go up. So yeah, when you hit 12 and 18 months, and then you're 18 to 24 months, and now you're talking a 1 to 2 year window, you are seeing continued improvements. It's just the scores, you're going to go from 95% on your quad strength to 100 from 12 to 24 months. There's just not that much of a, that significantly difference of a, statistically different improvement. But you can then go to subjective scores, some of the IKDC, scales where people can measure their function and sport activity level and some of the sport psychological readiness and retest them. And the further out the remove they get, the higher their scores continue to go up. Again, not statistically a huge difference because they were already meeting, return to sport criteria, but that continues to grow. We'll find some more like cortical mapping continues to improve at that 12 to 18 month, which just means that those patterns and your movement patterns and your how you move are just biomechanically, everything is still continuing to improve. And then you look at, let's look at some statistical, highlights of some professional athletes. You get someone from and you get someone from the NFL, and you can break it down by position even. But, running back, there's going to be a performance dip from that first year to second year back. Receivers also have a performance dip. versus like your O-line or D-line, you don't have as much of a performance dip in that first year of return. But then you get to those more skill positions, running back, receiver, and again, that second, third year, like, oh, they're feeling, they subjectively report from even just I can account for the guys that have been in here. They'll subjectively report like, I'm continuing to improve. I'm getting better. I feel faster. I'm back to normal is what they say. And again, it's hard to describe, but the way you feel at a 1 year mark, even though you're back to playing sports, and then a whole nother year level, you just kind of tap into a whole new potential. You tap into a whole new level. And then if we want to go on the shorter end of that, there's been some recent evidence where if athletes are at above 6 months and are passing all the criteria, can they qualify for returning, and what's that injury rate? I've personally had 3 cases recently, and there's a lot of education goes into it, and they were individualized cases. I'll give one specific one. Was a basketball player, kids coming up on his senior year in high school, looking for like D1 recruitment. If he would have waited till a 9-month return, he would have made 5 games for the season. He was actually able to return till non-contact at 6 months, and he was playing games at just after 7 months. He had a completely successful senior seasons, no hiccups, no issue, no pain, nothing. And again, a lot of education went into that case, just like the others, of patient education. I'm going through everything I just stated to you in terms of all the statistics we talk about to him. The parents are involved. We had, coach involvement too, for like player management, load management, and stuff like that, to help his availability and just kind of ramp him in. Surgeons also has to be on board. And again, as long as everyone can kind of understand the risks and they're okay with it, it's doable. It is doable. And the kid had an excellent senior season. And like I said, that's just one of the 3 cases I've had in the past couple of years where similar circumstances where those athletes it's either get back or don't have an option to play in college. And again, some of those athletes, it is a big risk. It's tough to talk about, but an injury could just completely ruin their sports career. But a successful outcome is what gets them into college and can literally get them a scholarship to afford to go to college. So there's a lot to consider when having those conversations. They get deep.
I know, for sure. So it looks like, you may have an outlier that can get better as soon as 6 months, and they may be able to participate as long as they're willing to accept and understand the risks that, like you said, each month after 6 months, your risk goes down by 50%, correct? Yeah.
And it's not a brag being like, we got this kid back and I've had a couple. It's more of just like, it is doable. It can be an option. And some of it might stand for like the quality of rehab that you get. I know in here, he was working 3 to 4 times a week. I was in touch with his strength coach, when I can divvy some lifts and compound lifts off to him so we can open the door and do more plyos in here. Like he had a full realm of like people helping him. Good outcome.
Well, good. And that's very encouraging, because I think a lot of people are like, I have someone, they may be ready. It's like, but it hasn't been time. So I think for anyone listening, if you have a patient or a young athlete, especially like in Brian's case, it's like, maybe they're a senior, maybe they're not going to play college sports, maybe they're not going to get the opportunity, but they're like, man, it's my last year. I want to play so bad. It's like, and they're there. I think it's just really important to highlight the educational piece, help them understand the risks, make sure that all the people involved, the coaches, the parents, the athlete, or the person themselves, the surgeon, like everyone's kind of on board with this process. And if they're able to complete a battery of tests with satisfactory scores, they may be able to do that, even though it is not the norm.
Yeah. And would even say satisfactory scores, like you're meeting the return to sport criteria.
Right.
Again, he's above 90% on everything that we give him. And biomechanically, there's no issues. And, numbers speak one thing, but then biomechanics on hop tests, biomechanics on, counter movement jumps and single leg assessments, stuff like that all come into play as well.
Sure. So there's quantitative and qualitative things that need to be addressed.
Good way to put it. Summed it up.
I 100% agree. And sometimes that's my biggest problem with research is it's like, how do I know that the person that was assessing the qualitative things did so to a level that I would agree with or beyond that?
Got it. Yeah. Again, that's where the standardized testing comes in. Gotta do your research in terms of who you're working with and who you're rehabbing with.
Sure.
A lot of one of the common slogans I always hear is, someone will brag, "Oh, I had surgery with, professional athletes, sports surgeon who repairs the, ACLs of Giants players." And then but then you choose the PT that's like in your local community that just, is your traditional outpatient PT clinic. Like you did all that research to find the best surgeon, but like 9 months plus of the work is put in, the surgery's 3, 4, 5, 6 hours long. And, you spend more than that during 1 or 2 weeks in rehab alone, let alone 52 weeks with your PT. So again, a lot more has to go into, the research of who you choose to work with. And that can go into a whole nother realm of factors of things to consider.
No, 100%. I 100% agree. And I know for anyone listening, we're going to try to keep this episode around 30 minutes. So we got about 10 minutes left that we're going to cruise through some things. So I'm going to ask this question, Brian, and then I'd like to kind of hit like benchmarks for timelines. Do you find that the reconstructions or the repairs have any specific drawbacks? Like for the bone tendon bone, like patellar tendon, or the just tendon harvested from the quad hamstring or peroneus longus, like how, like, are they going to be deficient in the like donor muscle for a period of time? Like, is that going to need to be trained additionally to overcome that? Like, what are the kind of drawbacks from harvesting a tendon from a different portion of the body?
Sure. They all have their pros and cons. I'll kind of hit on like the big three, your patellar tendon, quad tendon, and hamstring tendon, just because that's pretty much
that'd be great.
98% of the reconstructions we get. So when it comes to like patellar tendon, again, great for like your athletes and your patient populations. That's like 14, skeletally mature, like 14 plus years old.
Right.
It's got strong healing with the bone to bone graft fixation. Cons of that, there is an increased likelihood of, anterior knee pain. To usually see that in about 1/3 of people between months like 3 to 6, which is again, when you're running, when you're jumping, getting introduced to that. And the same thing, you get a little bit of tendinitis sometimes in that patellar tendon area. But that if that does come up, it's just got to be managed in clinic. You adjust what you're doing, and it should calm itself down, and you continue to reload. One cool study I referenced in the past was they did diagnostic ultrasounds of patellar tendon grafts at 3 months, 6 months, 1 year, 2 years, 3 years, 6 years later. And there was all still signs of remodeling. So it just goes to show us like that repair process is still undergoing. And again, just the load you put under it, the demand, the stresses you put on it is how it's going to kind of adapt. Again, if it's too much too quick, it's going to respond in a certain way, but it's just got to be progressively overloaded. And then again, with the patellar tendon graft, you are taking technically something that is part of your quad. So you will lose a little bit of quad weakness through there, but that's really the main weakness. That's the weak point. Sometimes it's a little more difficult to wake up the quad, but again, starting to, our evidence base, we're utilizing NMES, that neuromuscular electrical stimulation, the Russian stim early on for really, it's supported for up to 6 weeks of post-op rehab, kind of can help negate that. Going into quad tendon grafts, it's greater for your younger patients, a lot of high schooler grade, especially kids that haven't gone through maybe like their growth spurts yet. Lesser risk of like, anterior knee pain. And then it's also an option for people who have had a revision. So let's say someone who had a previous ACL reconstruction with patellar tendon graft and there's a re-tear, the quad tendon's the next thing gets taken.
Okay.
in a revision surgery. Yeah, there's going to be some inherent quad weakness with that. Again, you're taking part of it and you're disrupting it, during a major traumatic surgery.
Mhm.
And then sometimes with that, you can see little bouts of some quad tendonitis. But again, loading it the right way, with some specific exercises, especially some cooler stuff that's come out now where we can kind of manage quad tendinopathy and kind of apply it to quad tendon rehab, by basically doing some loaded knee extension from like beyond 90 degrees through a full arc has been very, very helpful. And then, yeah, when you get to hamstring grafts, you're going to be left with, I guess, the negative of that. You're going to be left with some inherent hamstring weakness. We see a lot of deficits, especially at like end range. So, pull your heel towards your butt and the non-operative leg can go all the way up. And then the right leg or the operative leg just can't get up all the way. So we find some limitations, especially in that like end range strength. And like eccentric strength. So just got to monitor that, load it properly. That's also good for younger patients. Usually definitely see that. I just personally see that more often in like your high school population and even a little more often in females. I'm not sure the correlation with that one though. And then it is a slightly smaller incision. So if there can be a little bit of a pro there. And then just when getting back into like your speed work and sprinting, it's definitely important to have your hamstring, quad to hamstring ratio within that 60 to 80 percentile, just like it should be for all athletes doing sprint work, just to reduce your risk of hamstring strains that usually can kind of creep up at your like later stage of that ACL rehab with hamstring grafts.
Excellent. So, we'll jump into kind of the last thing I wanted to chat about. And then for anyone listening that's like, whoa, you guys are saying so much. I've jotted down some notes. When Brian runs out of time, we'll let him pop off and I'll do a quick recap of the things we've kind of discussed today.
Cool.
So why don't we go over timelines? And I think there are some important ones that people are really curious about, like how long after surgery should their knee be straight? At what point are we behind on getting full flexion? How far into the process should they be able to do a squat? And at what point should they be able to start doing any type of single leg lunges / transitioning to running?
Cool.
Because I think that's where a lot of people get behind, because once people start running and squatting and doing all other stuff, it becomes a lot less. I don't know if that was the right way to say that, so I'm not going to finish that sentence. But I'm going to let you just kind of take it away. Like, what are the big benchmarks for you? Especially like, let's jump to, because you've said you've worked with a lot of professional athletes. If you're working with an NFL player, that knee is going to be under a load, which means it's very important that you get them hitting the benchmarks and progressing as efficiently as possible. Like, what are those benchmarks for you, and what is the general timeline for you to reach them?
Sure. I'll throw my generic, it's going to vary depending patient by patient.
Sure.
But I'll shout it loud, like get that knee straight as quick as possible, restore extension and hyperextension basically as quick as possible. First few sessions, that should essentially be back, getting into what's called like that heel pop, and being able to, do a straight leg raise under good quad control where there's no lag, where you're going to be set up for best success. So again, let's just say we're talking just straight ACL reconstruction, again, within that first few sessions, first week, that knee should be straight and we should be lifting up on our own power. Maybe some NMES might be supported for the first couple of visits, but then we're doing some, straight leg raises under their own power. If they can get to 90 and we can do some 90 to 60 like isometrics, that's also another like really great option, just to start restoring some open chain position like VMO activation, and I'll combine that with NMES as well. Flexion can just gradually come. I mean, if you're at 90 degrees within the first 4 weeks, I think you're on pace. And then really, between 2 and 3 months, that end range flexion should be restored, because again, that's going to be one of the criteria for returning to running, full range of motion.
Sure.
So we should be able to straighten and bend in a complete, full, pain-free arc. When someone, again, we might have some limitations. Let's add in a concomitant meniscus repair into that mix. Usually we're going to have some weight bearing limitations. Usually non-weight bearing times 4 weeks is pretty popular. I've even had a times 6, and I've even had a times 8 for one of the more complex NFL athletes I have right now. But it's typically a times 4 non-weight bearing. And I'm also starting to see a, 2 to 4 weeks is like a toe touch weight bearing with a, the knees locked in an extension brace to just, protect it, but it allows some forms of ambulation. So for, easier about getting around. What else do you want to hit on from there?
I'm curious about 2 things. At what point, if they can't do a body weight squat, is it a problem?
Body weight squats can start day 1.
Okay.
Again, as long as there's no weight bearing issues and you're demonstrating good quad activation with like a straight leg raise, there's no lag. I get it. You're checking off some of the boxes, and under the CPG, under the APTA CPG for ligamentous repair is introduce early weight bearing. So if we can do partial squats, mini squats right away, you're going to see a little bit of a shift. Just try to minimize that, working, a good quality range of motion for, to start. I've even had 1 day post-op, someone's coming in and we're doing mini squats. We're doing 3 to 6 inch step ups, again, because they're hitting, they're demonstrating that is appropriate. But at what point would it become a problem? If we're not hitting 90 degrees by around 4 weeks where you can squat down to 90 degrees, not a problem, but you got to start, figuring out what's maybe missing here. Is there any fear, apprehension? Is it a capsular mobility, patellar mobility type issue, a soft tissue restriction, an apprehension, like a mental block? And you just got to figure out the strategies to help them through that. Because come 2-3 months, I mean, you should be loading some squats. Absolutely. And considering, and as long as form and techniques looks great, stick with double limb loading earlier on. You don't need to jump to single leg box squats early on. Again, hammer the basics, do the basics well, set that great foundation. I like to remind the patients, you're in rehab mode right now. It's rehab.
Right.
When you get to the later stages and past the whatever, then you got to start looking at it as this is strength and conditioning, and just change the mindset there, and you get a good shift. Again, around 3 months is a great benchmark to be able to do. It's not really validated, but a good benchmark to do is 15 single leg box squats to an 18-inch box, pending their height, pending someone's individual height. 25 plus calf raises, single leg calf raises is also another good benchmark by that point. And again, when you're approaching that 3-month time period, the ability to hop on both legs, hop on one leg, because those are all precursors to then lead you into returning to running criteria.
Excellent. So it looks like by about 3 months, you should be pretty strong, relatively stable, beginning some hopping double leg, potentially single leg, and getting ready to run.
Yep. And then if we want to add in, show a little attention to those that had a meniscus repair involved, just look to push things at about a month, push things out about a month. And again, maybe running is not that 3-month timeline. It's closer to that 4-month timeline. And again, that time-based protocol is one thing, just meaning that physiologically, your graft is fixated, the screws are fixated, the bone is healing well for the tunnels. And then it comes into, do you have the more criteria based? Do you have full range of motion, no swelling, can hop on one leg, at least 70% quad strength in that involved leg, and a couple other criteria that says, now you're ready to run.
Got it. Well, excellent. I know it's we've reached the time that we discussed, Brian, so I'm very appreciative of your time.
Awesome. Thank you.
Oh, absolutely. And what I would say is take a minute to put in any plugs that you'd like. As already mentioned, you work for Edge Pro PT in North Jersey. But if you'd like to say anything else about yourself, or put a little plug for yourself, please do, and I'll let you go.
Yeah, no, nothing else to really add. Just encourage people to do a lot of their research. You go into a clinic and you're finding the place. You can ask a few questions such as how many ACLs do you usually work with a year, and that can be a two-edged sword. Is it a high number because there's a super high volume clinic like that mill kind of clinic, or is it a high volume because like people seek out that specific clinician for that criteria?
Right.
I think we are in a time right now where you can even niche beyond like an orthopedic specialist or a sports specialist or a geriatric specialist or a women's health specialist. And you can actually just even further niche down where like you can treat just runners. You can treat just MMA athletes. I can treat just ACLs. So again, you can find those people and those clinicians that have that expertise and can, experience that will apply to you and help you in that rehab timeline. Because again, that rehab is not that straight linear trajectory. You're going to have peaks and valleys throughout the entire process. And again, managing it, when to make the right calls. Do you need a referral back for anything adverse that could come up if you're not making certain progress? And again, to make sure you're hitting that progress. And again, working with someone that objectively just understands the importance of objective measurements. So you can take the brain, the emotion process out of it. Are they ready to go back to sport? I think so. Are you ready to go back to sport? You check this box, then yes. And you can give a strong, confident answer that, someone's going to go back and absolutely perform at their best.
Okay. Excellent. Well, thank you so much, Brian. I can just kick you so you don't have to worry about getting off, because I know you got to get going. But
sounds good. If the followers like a part two, maybe we could blend this into where we leave off at 3 months and what the next return to play maybe process could look like, and we can
absolutely. And I know a lot of people would be very curious to know more, like what you're looking at like your dosing, what you're giving people. I think that'd be a great idea. So
yeah, definitely.
So peeps, watch this, encourage others to watch this, and we're going to get Brian back.
Awesome. Thanks, Nate. We'll talk to you soon, all right?
Okay. See you, man. Bye.
Thanks.
Well, everybody, now you just got me, so I'm going to try to do my very best to give you a brief 1 to 2 minute summary of the things we went over today, because we were cooking. That was quite the pace we were setting there, and I know we didn't get to talk quite as much as I'm sure we would all like to, but that's why we'll look to see if we can get Brian on a second time. So when it comes to ACL surgeries, there seems to be 2 primary groups. There are reconstructions, where a different part of the body is being used to essentially reconstruct the ACL, or there are methods that you can use to repair the ACL itself so it stays native. The reconstructions, there seems to be 3 primary ones with a 4th outlier. The gold standard, according to Brian, was the patellar tendon graft, which is the tendon bone graft. And it seems to be better for those who are skeletally, tough word, mature, and those who are going to go back to sports that require especially more like rotation tolerance, change of direction, and things like that. The quad tendon is often the second place that they'll take the graft from, especially if the patellar tendon has failed and they've ruptured their ACL again. It's often used for people who are younger or for a secondary graft. But you need to be aware that there is going to be a bit of a quad deficiency in both the patellar and the quad tendons. And in the quad tendon, you're looking at probably 1 in 3 people are likely to have some anterior knee pain between 3 and 6 months, particularly for the patellar tendon. The hamstring tendon is the 3rd most common, and you're obviously going to experience some type of weakness in the hamstrings, especially during full flexion and during eccentric control. And this is often seen in younger athletes as well, much like the quad tendon. And as an outlier, the peroneus longus tendon can be used. And those are all of the reconstructions. The repairs, for those who are unfamiliar with, there's a Bayer implant, and it is essentially a collagen marshmallow. That's my understanding. They take some of your own blood, they saturate it with it, squish it in there, and then stitch the ends of your ACL up into it. So it essentially can clot and allow that to heal itself. The thing to recognize with the Bayer is that it is more restrictive, especially in the first 4 weeks. And so you won't be able to do as much range of motion or as aggressive strengthening and other exercises that you would with other surgeries. As far as general guidelines, you want the knee straight as quickly as possible within the first few sessions for sure, generally 1 to 2 weeks. They should be able to do a heel prop, a full straight leg raise under their own control, and you may be able to help facilitate that by using NMES or Russian, or use like a 90 to 60 degree arc, long arc quad isometric. Flexion, you should generally be at 90 degrees by 4 weeks, and full flexion, equivalent to the other side, including with overpressure, between 2 and 3 months. Squatting will depend on the person's quad control, but a good rule of thumb is that someone should be able to do a body weight squat at 4 weeks. And you may begin loading that squat potentially, if they are able to do so well, between 2 and 3 months. At 3 months, some general guidelines from Brian are a single leg squat to an 18-inch box. And of course, that varies based on height. If someone's 7 feet tall, that 18-inch box may be about a mile away from their hips. But you should be able to cruise through, I believe he said 15 single leg squats to an 18-inch box, 25 single leg calf raises. And if you're doing well, you should be able to also begin hopping on both legs or a single leg. If someone does have a concomitant meniscus repair, you'll generally extend most of those functional guidelines by about a month. So again, guys, thank you so much for listening to this. I know it's a shorter episode. I hope you like it. And I'll be putting out more, surveys to kind of see what episode length you guys like most. Because as much as I would gladly sit down and talk to someone for 2 or 3 hours, I know that a lot of people are not necessarily into that, listening to that length of a podcast. They feel they get lost. They listen to it for 15 minutes at work. They have a busy day at work, and then they're like, I can't figure out where I was again. So we may do more of these shorter episodes and plan on doing them in parts. So everyone, thank you so much for your time. If you wouldn't mind, if you're not already subscribed on any of the podcast platforms or Instagram, I'd love to have you join the community. So as always, guys, thank you so much for your time. Happy to have you, and take care.